I'm Michelle Kittleson, professor of medicine at the Smith Heart Institute at Cedars-Sinai in sunny Los Angeles, California. And I am delighted to give you an overview of my book, Mastering the Art of Patient Care. The bottom line is this book is based on all the mistakes I made and the wisdom of my mentors, so you don't have to make all the mistakes yourself, and maybe you will benefit from the wonderful mentors that I had in my career. So the book is organized into 4 sections: building your medical foundation, honing your clinical judgment, establishing your medical style, and optimizing the care of patients and yourself. And each section has a number of chapters. And because this is going to be a quick snippet, I'm going to give you highlights on a few sections: building your medical foundation, honing your clinical judgment, and being a woman in medicine. I hope you'll check it out if you're interested in some of the other sections here. So let's talk first about medical school. And I'll tell you what I tell everyone who asks me for free advice about medical school. It's not fun. It's a lot of hard work. It's a lot of learning facts without context until you know enough that they're put into context. So to survive the early years, which feel like a lot of drudgery and memorization, you have to find systems that work for you. The systems that worked for me were most often cheat sheets, meaning writing down the facts over and over again and finally distilling them into the bare bones that I needed to know. The very act of writing would make it cement itself into my brain. And study questions, because studying by asking and answering questions is a form of active learning. And the best thing about the cheat sheets and the study questions is it forced me to engage. So instead of worrying about all I didn't know, I was making a plan to learn it. And then keeping hope alive. How do you not lose the passion for medicine when you spend your days memorizing how to pronounce long words you never knew existed? Well, part of that is I found medical dramas and medical narratives were really helpful. I had a friend who would do shifts as an EMT to remember the joy of clinical medicine. You'll find your way. When it comes to the clinical years, they're exciting in the sense that you're finally taking care of patients, but they're also really uncomfortable in that there's so much uncertainty. Where do you sit? Where do you stand? When do you speak? When do you not speak? What do you say? And that changes. Those rules change with every rotation you go on. So I find these 3 tenets really helped me. Number 1, feign enthusiasm. When you're in the midst of a rotation and you're not sure if you ever want to do it, you can pretend to be excited. And sometimes do you smile if you're happy, or are you happy because you smile? Just feigning enthusiasm leads to enthusiasm, begets enthusiasm. It also begets a certain amount of excitement from those who are teaching you to want to teach you more. Committing to the rotation. I would always imagine whatever rotation I went on that I had to be that when I grew up. Like forevermore, I was going to be an obstetrician, so I better learn everything I could. If you have that mindset on every rotation you go through, because it might be the last time you ever deliver a baby in your life, then you will get more joy out of the rotation. And recognizing that at some level, the price of service is cut, meaning if your resident asks you to help prep the notes for all the patients on the service, but because you help the resident by doing that, then they have more time to teach you, it's an even bargain. Laundry, dry cleaning, that doesn't fall under those categories, but certainly helping the machine of patient care move forward is important to do. So one thing I learned is with the patience and dedication to the vocabulary and grammar of medicine, you will soon be able to appreciate the poetry. It will happen. And medical school cannot and should not feel easy, but it should feel worthwhile. Moving on then to becoming fluent in medicine. There is a really detailed section, a chapter in the book about how to give a beautiful oral presentation and the art of writing a note. Because so much of what you do in medicine will be judged by how you communicate. And communicating well will help you think clearly, speak clearly, act clearly, and you will shine. Oral presentations have a script. There's a template. You stick to it because people are used to hearing things in the same way. It's not the time for creative soliloquies. Anything you say, you must know. Patient-directed reading and looking things up is the best way to learn. If you say it, you must own it and know everything about it. And practice makes perfect, whether you practice to your dog, your mom on FaceTime, or just yourself, practicing your presentations will make you better at it. When it comes to the note, remember to read it through. It should make sense. Shorter is always better. And remember, just like if you say it, you own it. If you write it, you own it. If you've written PTLD in your note, post-transplant lymphoproliferative disorder, you better know what that is. Things you don't want to put in your notes. Continue to monitor. No one knows what that means. It's very nonspecific. Follow up as outpatient. Don't defer. Own the problem while you're caring for the patient. Avoid nephrotoxins. Who knows what they really are? Be specific. The patient is on an NSAID and should stop it. Gentle diuresis. Again, very nonspecific. The goal, I's and O's are X. And consider X, Y, Z isn't enough. Whenever you find yourself wanting to consider something, make it an if-then statement. If X happens to the patient, I would recommend Y. Put your nickel down. That's how you make decisions and write notes that are helpful for other people caring for the patient. Moving on to your career path. You're going to think about research. You're going to think about choosing a specialty. You're going to think about picking a training program. Here's some advice. When it comes to research, when you are very early and unformed in your career, pick the mentor, not the project. You don't know enough to be truly wedded to a protein of some or organism of some kind, but a good mentor will show you how good research is done, will guide you. Always start a little more basic than you're interested in, because it's very hard to go backwards. Meaning, if you think you're going to love clinical medicine, try to do some research in translational medicine early in your career, because you may decide you love it or you don't, but you've had that exposure, because it's hard to do that as you get farther on in your training. Choosing a specialty. Much of it comes down to process of elimination. What do you not like? What is not good for your temperament or your lifestyle? Who inspires you? Often your mentors, you'll find people you want to be like. And what about lifestyle? I'm sure there are dermatologists who work 12-hour days and cardiothoracic surgeons who achieve work-life balance, but you have to remember that certain specialties will not have the same level of flexibility, and how important is that to you? When it comes to picking a training program, think about the 3 most effective tenets of medical education in order. Volume, the more you see, the more you will learn. Autonomy, the more you own the patient, the more you learn. And mentorship, you will be guided by the wisdom of your role models. So when you're picking a training program, ask the current trainees about the volume. What's the culture of autonomy and support? And do they find willing role models and mentors? Because your medical career may follow one of many different paths, and the direction that brings you joy may change over time as you learn or grow. So to give you a case study, I'll tell you a little bit about my career path. Like pretty much everyone, I went through college, medical school, internal medicine residency, cardiology fellowship, advanced heart failure transplant cardiology fellowship before I finally got a real job. Too many years to even contemplate. So why did I go to medical school? Well, I was told to. I was a 5th generation of doctors in my family. I didn't really have a choice as an only child. Fortunately, I got lucky. I loved it from the very first day. What about internal medicine residency? Why did I pick that? Well, for me, it was the most efficient use of all the knowledge I'd memorized in medical school, and I had the most extraordinary mentors in internal medicine. Why did I pick cardiology? Well, I love the pathophysiology of things like shock and heart failure. I love the fact that history and physical matters. You can't diagnose unstable angina without talking to a patient. You can't diagnose decompensated heart failure without examining a patient. I like the evidence base of the rich clinical trials we can use to help our patients. And interestingly, emotionally, I can wrap my head around dying of heart failure in a way I can't when it comes to cancer. I think I would be too burned out to ever be an oncologist and watch patients die that way. And mentors, you see a theme here. It's always about the mentors. Heart failure transplant was a similar trajectory. I love the human drama of leading patients through the transplant process. I like being able to do a little bit of everything, chronic, long-term, short-term. and it comes down to mentors. And you will find there are things that appeal to you as you move along your career path. So to think about honing clinical judgment, we can think about diagnosis, tests and interventions, and how to be a good consultant. When you think about diagnosis, read a lot of notes. Think about the highest yield questions, which for me are generally, what triggers your symptoms? And why did you choose to come to see me now? That will often give you a sense of the differential as well as the severity. And you don't just listen to the patient, you observe the patient. How are they dressed? How do they walk? How do they speak? Who's with them at the visit? There are so many clues you'll glean. When it comes to tests and interventions, the most important thing you're going to learn is Bayes' theorem, that your pre-test probability guides your post-test probability. If you already know the answer, the test is going to be negative, then likely the test shouldn't be done at all. Know the difference when you're interpreting a test. What are the pitfalls? What are the classic false positives and false negatives you need to watch out for? And then what are the band-aids versus cures? And what's the golden rule? Before ordering a test, have a plan for an abnormal, normal, and indeterminate result. And if this thought experiment demonstrates a test won't change management, or if you don't know how to interpret or act upon the results, you shouldn't be ordering it. And remember, you don't do anything to a patient if it won't help them feel better and live longer. And when you are the consultant, the true expert in the scenario, how do you do a good job? Well, when you're calling a consult, you call early, you have a specific question for your consultant, and you prepare the patient that the consultant is going to be coming to see them. And as the consultant, you know when to stay in your lane to operate within your scope and when to push to try to get more information. If you remember these pointers and you follow the golden rules here, you will have the best clinical judgment for your patients. And the final thing I wanted to talk about was being a woman in medicine, because there's certainly, I think, challenges in training, parenthood, and career. I've certainly been in the role of not being believed and thinking to myself, what can I do differently to make my voice heard? Part of it is claiming your role, being very clear that I am the physician in charge of your care and I have the expertise with my team to care for you. Sometimes humor and sarcasm can help. If a patient says you don't look old enough to be a doctor, I say, live in Los Angeles, we've got great Botox. Sometimes if you read the room right, that can help break the tension. Sometimes it's about calling out the elephant in the room, accepting, I get the sense that you're not comfortable with me as your physician. Tell me if I've read this correctly and what I can do to give you the best care. Because sometimes no matter if you claim your role, if you try to diffuse the tension, it's not going to work. And you have to know when to cut your losses and give the patient what they need. Parenthood. There's no right time to have kids. There's no wrong time to have kids. I had a mentor who told me you need 2 or 3 criteria to be a successful parent and physician. You need a flexible spouse. You need dependable childcare, or you need family willing to help. And if you have 2 of those 3 things, you can make it work. What are the unfounded fears? There's 3 that many trainees come to me with that I myself had when I had children. Number 1, you won't be a good doctor after children. Clearly nonsense. You don't need kids to be a good doctor, but it will enrich your medical career in many ways. Number 2, your kids will forget you and not love you if you're at work all the time. Also not true. Remember, especially babies just need some warm milk and a nice swaddle and a place to sleep. And you will always be an important part of your kid's life with the quality time you spend with them. It doesn't have to be endless quantity. And the third unfounded fear is you'll never get it together, because when you have a newborn, you really feel like life is on its own trajectory that is impossible to maintain, but you will. There will be ups and downs to everything. There is a season. And that leads me to career. Your priorities are right because they're yours. And if there comes a time in your life where your family is more of a priority than any academic pursuits, you have to feel very comfortable owning that. Number two, comparison is a thief of joy. There might be colleagues of yours who trained with you, whose career has gone on a different path than yours, and that's okay, because comparison is a thief of joy, so don't compare yourself. And remember, there's more than academic medicine. And to show you a case study, I'm going to tell you about my journey. So what have I plotted here? I have plotted my PubMed research citations by year to tell you a story. So here we have fellowship, a lot of good progress, early career trajectory, moving on the upswing. And then you see I kind of fell off a few cliffs in my productivity. And that was when I had kid 1, kid 2, and kid 3. But had an upswing after each one. So what's the first lesson here? The first lesson here is it's okay to take breaks. It's okay to say no to things. After my kids were born, I only had 2 priorities: keep my patients alive, keep my kids alive. Everything else I said no to, and I had the inner peace of knowing that it was okay to take breaks, that I would be able to recover from them if I wanted to. Second, if you look at the red line, that's when I was first or senior author. What do you see between 2012 and 2018? Basically nothing for first or senior author, because that was a time with all those kids, I didn't really love research. I didn't want to spearhead research projects, and that's okay. But what ended up happening, and that's that green line there, is other passions. When I started writing essays, poems, and eventually this book. So remember that life happens in stages. You don't have to do it all at once, and you will find other passions in medicine when the time is right. So I'd like to thank you so much for your attention. The book is available on the Springer website. It's often free of charge through many medical libraries and institutional subscriptions. I do hope you'll check it out for the tips, tricks, and pearls. Thanks so much for your attention.